Good morning, everyone. I want to talk about abdominal desmoid tumors and I want to present our series from our institution. Desmoid fibromatosis is a benign malignancy that represents a challenging problem for both physicians and patients because, despite its rarity, physicians have always the doubt how to cure desmoid fibromatosis with surgery, radiotherapy, active surveillance, or with chemotherapy. And the patients have always to keep in mind that even if it's a benign malignancy, desmoid tumors can lead to death according to its local aggressiveness. And desmoid tumor behavior is unique, is very rare, and above all, it's unpredictable because some of them remain stable all the time. Some other may have a regression, and others may progress very rapidly. And what we know from larger series is that we can select a group of patients that can have a great advantage of active surveillance because they remain stable or even they have spontaneous regression, and this happens in 20% of cases. And the history of the treatment of desmoid tumors has changed during times, and this is because at the beginning and some years ago, surgery was considered the mainstay treatment for desmoid tumors. But then we have changed and we choose active surveillance as the principal treatment for desmoid tumor. And this is because we have an important perioperative complication, so with a high rate of recurrences, even after R1 surgery. And recurrence rate ranges from 20 to 60% of cases in other series. And so we chose active surveillance as a mainstay treatment for desmoid tumors, and radiotherapy and surgery mainly for local control, and chemotherapy in case of progression or in case of complicated intra-abdominal or extra-abdominal desmoid tumors. And this is our series. This is the series of European Institute of Oncology from January 2003 to March 2019. And as you can see, we have 22 patients, 13 were males, and the mean age was 41. And these are our clinical characteristics. 86% of cases were symptomatic patients with abdominal pain in 45% and abdominal mass sensation in 41 cases. And they were all biopsy proven, with 4 patients which were biopsied outside our center, and then they referred to our center. As medical history, we have 45% of patients with a previous trauma or a previous surgery. And about tumor size, our patients had tumors with big size, more than 5 centimeters in 86% of cases, and tumor were mainly located at the mesentery in 72% of cases, and big vessels were involved in 70% of cases too, with big vessels, abdominal aorta, iliac vessels, and inferior vena cava. And here you have our frontline strategy. So 19 patients, which are 86% of patients, were treated with upfront surgery, and 3% received medical treatment with the medical schedule reported here. And of those patients who underwent surgery, 11 had conventional surgery, while 4 had an explorative surgery with incisional biopsy outside our center, and then they were related to our institution and then underwent a wait-and-see strategy, and the other 4 had a urgent surgery due to overcoming complications such as bowel obstruction, perforation, hemorrhage, and 70% of cases had an R0 surgery, while in 5 patients we had a marginal or intralesional surgery, with one case not reported as a marginal status. And we had 53% of cases of multivisceral surgery, with a postoperative morbidity recorded in the 30 days after surgery as 13%. And we had no postoperative mortality recorded. We employed a multimodal approach in the 4 patients who received biopsy outside IEO, and then they were referred to us, and we reserved for them the active surveillance. And for 1 patient who had surgery and afterwards received the chemotherapy because of one surgery that progressed, and 2 patients had tamoxifen and Celebrex after surgery because of progression, while 1 patient after chemotherapy underwent surgery because of a complication of chemotherapy, a bowel perforation, and after surgery he was underwent to radiotherapy as well because of intralesional surgery, and afterwards he received the chemotherapy too because of progression, rapid progression. And this is our patient outcome and follow-up. With a median follow-up of 80 months, we have only 1 patient, one surgical patient who we have lost at follow-up, and we had no evidence of disease in our surgical patients in 71% of cases, which is a very high percentage. And no deaths, neither from disease and neither from other causes, were recorded. And 26% of patients, of surgical patients, were alive with disease. But what about our non-surgical patients? In this column, we have considered the patients who received active surveillance after the incisional biopsy outside the IEO, and the 3 patients who underwent directly to medical treatment. And we have 42% of patients who are alive with disease, and only 1 patient who have regression, complete regression of disease, and 3 patients who died. One from intra-abdominal desmoid tumor, and this was a FAP-related one, and the other 2 from other causes. And so we can say that from larger series, large and block surgery is no longer the cornerstone of treatment of desmoids because of the high relapse rate, which can be up to 60% of cases. We have to say that in our series, we did not have a relapse rate so high, but our patients had a multivisceral resection, so they paid their oncological outcome with multivisceral resections. And we can say that surgery remains a mainstay treatment in case of important symptoms or rapid progression or complications. To conclude, we can say that our series was mainly surgical, and this is apparently in contrast with literature, but we have to see and we have to underline that our patients were mainly symptomatic and with big tumors, and their tumors were mainly localized in mesentery, and 2 of them had complicated intra-abdominal desmoid tumors. And when we choose the surgery, recurrence and morbidity were relatively low, and this means that we have the 53% of multivisceral surgery with 2 cases of urgent surgery, but our patient had a good prognosis for sporadic resected intra-abdominal desmoid tumors, and 26% of them were alive with disease. And medical treatment, consistently with literature, was researched in case of surgery was not feasible, and with aggressive intra-abdominal desmoid tumor with poor outcome, especially those related to FAP. And these are our points of weakness. We have to see that our series was small, and this was a retrospective analysis. Moreover, our data are heterogeneous because we have mixed them with patients who were biopsy outside Yale, and we have missing data because we have no information about quality of life of our patients after surgery, and because we have one patient lost at follow-up. But when we choose surgery, our choice was good because our oncological outcome was good with small relapses and with patients alive without disease. And we have only to underline that our surgery was a big surgery because our patients paid their oncological outcome with multivisual resections. So I want to thank you for the attention, and I see you goodbye.